Allora, adesso parliamo di una tecnologia che si sta diffondendo lentamente in Italia e che in Italia perlomeno viene dal mondo del biohacking, che è un mondo un po' particolare, non è proprio rigorosamente scientifico, ma in Germania la stessa identica tecnologia è già stata riconosciuta al Sistema Sanitario Nazionale, sperimentata ampiamente, è utilizzata nelle riabilitazioni cardiologiche e riabilitazioni neurologiche. Uno studio molto importante fatto alla Charité di Berlino, che è il più grosso ospedale universitario di Berlino, sui pazienti long Covid, ha dimostrato che facendo gli esercizi di respirazione in fase ipossica alternata iperossica si induce di fatto una rivascolarizzazione dei tessuti e un aumento del trasporto di ossigeno. Adesso switcho all'inglese perché lo speaker è inglese. So Thomas Michaelsen will speak about this technology, which has been highly validated in Germany and is now coming to Italy. And I think he will show you very interesting data. We are working on this technology in SoLongevity because there are data from the Luigi Ferrucci lab in United States that show that the hypoxic phase is actually a potent inducer of epigenetic rejuvenation. So it's something we really count a lot on in our clinic for the future. And thanks for Thomas to be here.
Hello. Thank you for the introduction. My name is Thomas Michaelsen. I come from Germany. I'm involved in this project for now a little bit over 4 years. You know, I come from the background of, should I go a bit closer? I come from the background of being a nurse. Most of my life, for about 15 years, I worked on intensive care, and about 5 years ago, I got called up by my dad after a night shift, and he said, Thomas, I have a guy here. I would like to introduce you to him. He has a respirator, and you know respirators. Maybe you should have a look at it. And this is the device that I found. Now, this is a picture of the first clinical application in Germany. Basically, it's not a respirator. That much I could say. And what I saw is this. Please pay attention to the upper right corner. You can see the current oxygen saturation. The upper graph you can see is the current concentration of oxygen that gets applied to the patient. Generally in the air it's about 21%. Here we go down to 11-12%. And as you can see, the oxygen saturation of the patient goes down to about 84% until it switches and gives the patient a hyperoxic dose afterwards to reoxygenate. So, with my background, the first questions I asked was, why the hell would you do that? This was the answer from the developer, who's also here today. And I was even a bit more confused, because why would you decrease oxygen saturation within a patient who is ischemic? Right? And the answer to that is not as clear-cut, but I try to convey it relatively condensed to you here today. So currently in science, people are trying to break down the effects of hypoxic conditioning from the genetic up to the systemic level, where we can see basically the functional outcomes within the patients. Overall, this is quite a complex concept, and the more you go to the left in this graph, the more things still have to be investigated. However, there's a couple of interesting effects that I'm going to go about, and I want to start with the basic premise. So, generally, when we go to altitude, the oxygen in the air gets thinner, so there's less air or less oxygen. And it offers a good introduction to this technology because basically there are some differences to intermittent hypoxia, but it offers a good starting point. When we go up a mountain, our heart rate increases, our breathing increases, and our SpO2 values decrease. When we come back down from the mountain, those values normalize. Now, athletes use this for quite a while, and they use this in order to create long-term adjustments like erythropoiesis and improve their oxygen utilization. One of the methods that they use is live high, train low. So they go about 3,000 meters in altitude to sleep there and then do training at sea level. Intermittent hypoxia focuses on short to medium-term adjustments through short, moderate exposures, either at rest, which is referred to as IHE or IHHE, or under additional physical exercise, IHT or IHHT. Generally, people refer to this as IHHT, although most of the time people apply actually IHHE. So the terminology, you have to bear with me a bit. Usually we do IHHE. So why intermittence? Some of the unique effects that we have with intermittent hypoxia is, for example, so-called hypoxic ventilatory long-term facilitation, meaning an increase in minute ventilation within the patient after the treatment. Also, clinical research shows improvements in blood pressure and in resting heart rate. Another very interesting point that Alberto already started to point out was it has a unique interaction with our nervous system. There's a specific pathway called the Q pathway that is responsible for our nervous system response to moderate doses of hypoxia. It's specific to moderate dose, not to severe dose. This is currently investigated by the University in Florida. Now, the current scientific consensus for the underlying mechanism of hypoxia, or generally hypoxic conditioning, is rooted in hypoxia-inducible factor. Some may be familiar with it. Hypoxia-inducible factor is changed our fundamental understanding of how our body reacts to different or varying levels of oxygen. And this fundamental research has gained the Nobel Prize in medicine in 2019. Now, it solves as a basic understanding of how it works on the genetic level, and it basically shows like the cascade of how this interacts with our body on the different levels and is the so-called underlying factor for this. Now, the main challenge in all of this is dosing. Imagine taking a bus with different people from different ethnicity, different ages, different preconditions, and driving with them up Mont Blanc. You will see very different responses within patients. Some people might try to get off the bus at 2,000 meters, some at 4, and some might even be okay going up to 5,000 meters. Now, the way that we handle this is by implementing an algorithm that evaluates the cardiorespiratory response of the patient. So we basically expose the patient to hypoxia, we measure their response, and then an algorithm determines the treatment parameters on an individual basis and fully automated. Then we apply intermittently hypoxia exchanged by hyperoxia. We give a slight dose of hypoxia to the patient because most patients tolerate it better. This might also have other benefits to give hyperoxia. However, there's still some research to be done on this. Now to the trial. So I dove into this kind of technology after I got introduced to it, and I think it was about 3 months after I got my first confrontation with the device that we got contacted by Charité Berlin. It was the height of COVID times, and they read some of the literature about it, and there was some indication for them that this might be helpful for COVID patients. So I went there and introduced the device to them, and they gave me pretty much the same expression or the same reaction that I had initially to the device. And on the right side, you can see Professor Döner. I had an interview with him last week, so I can mostly quote him on the results of the clinical trial. But when I introduced the device to him, he looked at me and said, "Great, Mr. Michaelsen, but what is this supposed to do with long COVID patients?" And my answer to him was, "I have no idea." And he said, "Great, I like your honesty, we should try it." Now, you might think this is not very German, and you're absolutely right to think so. However, this is how we started. So overall, COVID-19 is a debilitating condition. And although there are many symptoms that these people suffer from, mainly shortness of breath, weakness, and fatigue are a common factor within these patients. These symptoms lead to poor quality of life and a delayed return to work. And this is also quite a strain onto our economic and our medical system. So far, up until this trial, there was no respiratory therapy that existed for long COVID patients. And intermittent hypoxia was promising because we can see throughout the clinical trials that have come before that this therapy has the potential to improve or enhance exercise performance. It was a little bit difficult at the start. I mean, you're applying hypoxia to a vulnerable patient group, but the device that we did it with had already medical certification. It's a class 2B medical device. And the body of literature that has come before already hinted at those things. So in the end, it got through ethics committee. This is how it looked in the clinics. We worked together with the Median Clinic, which is a big German rehab provider. They had basically like a big cohort of patients where they could conduct the trial. And the study was designed that we had an intervention group and a control group. Overall, 150 patients were in this or conducted this trial, and half of the patient group got the standard rehabilitation program, and the other half got the standard rehabilitation program plus intermittent hypoxia, hyperoxia with the reoxy. So they got around 8 to 10 sessions and were exposed to this personalized program, and usually the hypoxic exposure was about 10 to 12% and the hyperoxic phase 30 to 35%. Times varied because between patients the settings were very different. The main and primary endpoint was the improvement in 6-minute walking test. Why 6-minute walking? Because it's a very good indicator. 35 meters improvement in a 6-minute walking test is deemed as clinically significant. And the outcomes were even surprising us. I mean, in contrast to the control group, we had a 2.8 times improvement in 6-minute walking test. So not 35, but 91 meters. We also saw a dramatic increase in stair climbing power in contrast to the control group. And the secondary endpoints that were evaluated through Borg scale, for example, showed significant increases or significant improvements in their dyspnea, fatigue symptomatics, and their generally quality of life. They also implemented a median recovery score, which is basically a testing battery that included several questionnaires. So the tertiary endpoint, and those were basically observations throughout the trial, were the significant decrease in blood pressure and increase in hemoglobin mass. Now, at the start, I introduced it with altitude training. People go to altitude to do this. However, there's an important distinction. If you want to increase your hemoglobin mass in order to have better athletic performance, you better go up to the mountain because you need about 100 hours exposure to hypoxia, so chronic exposure to hypoxia, in order to increase hemoglobin levels to a level where you can feel it in exercise or in athletic performance. And most importantly, there was no adverse effects. If you put this into graphs, this is what you see, although I have to mention that there are some limitations with this. So since this was an open label trial, there was no randomization in this. On the other hand, though, you could see these improvements throughout almost every test battery that they did. Also interesting to note is the improvement in hand grip, in spirometry. And one thing that isn't part of the slides, but that you can find if you look up the trial, is a decrease in C-reactive protein. So inflammatory markers decreased for these patients. These are the locations that are by now using Reoxy in Germany. And the Median clinics are rolling out this therapy more and more. We have a couple of research projects going on. There's still a lot to be done, but things are heading in the right direction. Additionally, as Alberto already pointed out, there's now a center in Milano, and we're very proud to be here to have the first 2 Reoxy devices in Italy. This is just a general systematic review that's part of the literature body that has evolved in the past few years. So there's constant work being done to evaluate this treatment in various conditions. I mean, the talk is about long COVID, but initially this device is certified for what it was put out for was the increase of exercise tolerance within cardiac patients. So we do see the potential implication, or we do see like consistent outcomes in regards to exercise performance, but also cognitive performance in various modalities. Now, these are further references that I used for this, for creating this presentation. And if you want to know more, feel free to scan our website through the code, and I'm happy to answer any questions that you have. And thank you very much for the invitation.
Domande?
Hello, I'm Dr. Tavera. I would like to ask you whether have you any experience of you are planning to identify eventual combination of hypoxic training and hypobarism. For instance, have you considered to set up such a device at La Paz in Bolivia and to see if there are differences between sea level results? Also, for instance, to hormonal patterns like EPO or...
You're probably familiar with the hypoxia, hyperoxia paradox, if you talk about that, right? If you have like a high span between oxygen levels within the body, you can basically create like a relative hypoxia. This might also be some explanation for some of the effects that you have with hyperbaric chambers, but indeed, yes, if you have time later on, I have a colleague with me who actually where they actually implemented this in combination with hyperbaric treatment in Israel. So you're welcome to talk to us afterwards, and we can give you some insights on that.
Thank you. Thank you so much.
I have a question. What is the best biomarker of efficacy, if there is any?
The best biomarker depends on the modality that you treat. Really.
On a standard treatment, say 3 sessions a week for 5 weeks, what would you measure before and after to show the patient is actually improved? Yeah, so as I said, we see most consistent improvements in functional outcomes when you do like functional testing batteries. I mean, I mentioned the neuropsychiatric disorders and especially like spinal cord injury. Spinal cord injury, the main marker that they did was hand grip, but you have to measure it at a specific time. And then if you look, for example, for silent inflammation, CRP seems to be a good marker, although most people actually apply high-sensitive CRP because you see results quicker. And if you go for other modalities, for example, if you go into like load impairment and those kinds of things, it's definitely at the moment 6-minute walking and stair climbing power. How about VO2 max?
VO2 max is a thing that's relatively difficult. So we see it in FEV1. We know that VO2 max has been used, for example, for athletes quite a lot, but it is still a difficult marker in regards, if you measure VO2 max during the treatment, of course, VO2 max goes down. And if you apply it and do too much exercise while you do it, we know this from sports medicine, you actually also see a decrease in VO2 max. So the literature is not consistent on that, but it would be interesting to investigate if you just do exposure.
Yeah, I'm asking because I had an increase in VO2 max after treatment.
Perfect.
Yes. Gian Domenico.
Then can I understand it can be a major performance improvement for the athletes like us, all our international athletes playing whatever sport? And if yes, do you have any case of an athlete using it today?
We do. I'm not allowed to close it at the moment, but what I can tell you, it's we see it currently so it's very difficult if you go into like high performance athletes because the cohorts are very small that you can acquire. You can't just mix soccer players with swimmers, and you get two inconsistent data sets. Where we see it currently, where it's very promising, is in sports rehabilitation. So people who had sports injury, for example, and they can't put full load on their limbs, then you can use this as basically like as an additional load, right? Instead of putting more load onto the bone or onto the muscle, you put more load into hypoxia and increase the functional hypoxia that you have in the muscle, and therefore can probably help them like basically build up muscle quicker and keep up their performance better.
I found this super interesting also because I saw the same thing in mesenchymal stem cell of lipogems. We were studying methods to boost further the function, and hypoxia is one of the best. We were rushing to make the transplant as soon as possible, of course, not to have too much hypoxia. No, it's better to wait at least 15 minutes, 20 minutes to do a light shock and make them to work better. This is a very practical application of what you are saying.
I mean, like in cardiac surgery, you also use that as preconditioning, basically. So people just like cut off the blood supply to the heart for a short amount of time to do a form of preconditioning. And I had an interesting talk with a cardiologist near my hometown, basically, who told me that he knew this approach from getting people off ECMO, where they put people intentionally under hypoxia before they remove the ECMO from them.
But this is exactly a form of stress.
Yes.
So, mechanical, in this case, hypoxia or any other.
Thank you, Thomas. Thank you.